morning. Good morning. I'm Dr. Kabulu Kading-Arnold. I'm an obstetrician gynecologist working at Mbabane Government Hospital as a consultant. And I'm also holding a degree in ultrasound scan in obstetric and gynecology. I'm also a member of International Society of Ultrasound in Obstetric and Gynecology. Today, I would like to demonstrate how we perform an obstetric ultrasound scan. But before we get started, I would like to first introduce to you how does the ultrasound machine work. The ultrasound is actually a sound which is beyond 20,000 Hertz is a frequency of sound. Here, I would like to remind you that the sound that a human can hear goes from 20 Hertz to 20,000 Hertz. Every sound beyond 20,000 Hertz is called ultrasound, and that ultrasound is used to create an image which is used to examine the fetus during pregnancy, what we call obstetric ultrasound scan. Okay, the ultrasound scan machine is composed with two big units. We have the probe. I will in a bit explain what is the probe, and this probe is connected to a scanning unit, and the scanning unit provides us with controls and displays the image on the screen. Now, talking about probe, the probe is the one producing the ultrasound to create the image. And inside the probe, we have some quartz crystals we call piezoelectric crystals. They are arranged inside the probe in a certain way, and when a current is applied to those crystals, they change rapidly their shape, and that changing of that quick change in shape we call vibration is the one generating the ultrasound, and that ultrasound actually travels in tissue as a wave of compression, and it goes at a certain frequency. That's why we were talking about ultrasound being a sound which create waves at a frequency of more than 20,000 Hertz. So now, probes, they come in different shape, size, and as I said prior, the piezoelectric crystals are arranged differently inside of the probe, depend on the type and the size of the probe, and depend on which area of interest we would like to scan. Like this one is a curvilinear probe where the piezoelectric crystals are arranged in kind of a curvy line, and it produces an image which is a fan shape, or what we call a sector shape image. We have those which are linear probes, and the piezoelectric crystals are arranged in such a way to create a rectangle shape image. I would like to talk now about the scanning unit. The scanning unit is connected to the probe by a cable, and this scanning unit, as I said prior, provides controls and displays imaging on the screen. Talking about the controls, when we use them to optimize and create a more clear image on the screen, that's what we call the knobology. So let's go in a little bit into details, but I would like to remind us that The scanning unit comes in different shape, in different sizes, and has a kind of big wide number of controls, but all of them, they have some common controls that we use to optimize our ultrasound scan image. The first one being the overall gain. The overall gain is actually a control which helps to amplify the signal that is being received as an echo from the ultrasound which has been sent from the probe. And it's used quite similarly, the very same way we would have turned up a volume on a stereo. So the higher the overall gain, the brighter the image on the screen. We'll demonstrate it in a bit on a patient. A second one is the TGC, time gain control. The time gain control actually is one of the control which helps to amplify the signal at an area of interest. Should I here say that the deeper the tissue or the deeper the layer, the less resolution we have. And so to optimize the image, we use TGC to try to increase the gain at a certain level of depth, which is very, very important. Another one is the freeze to freeze. We have the freeze control, which helps to freeze the image. For instance, when we would like to perform some measurement on the fetus, we need to freeze the image before we start measuring. And for that, we have a control which helps us for those. And we have M mode. M mode helps to calculate the fetal heart rate and see the fetal heart rhythm. It's very, very important as well. And so we have the depth, which allows us to concentrate the ultrasound at a certain level of depth, which optimizes as well our scan. And some others depend on the brand of the ultrasound machine we are using. So soon enough, we will start performing the ultrasound scan on a patient to try to put into practice whatever we have said. Now, as we will go and get the patient, the first step before starting an ultrasound scan is preparation for scanning. And the preparation for scanning, what do we do exactly? We first talk to the patient about the ultrasound scan. What is it all about? What is it that we are doing? And what is the indication of the ultrasound we want to perform? And if she has some question, she will be allowed to ask those questions before we get started performing ultrasound scan, and before we enter all the patient details in the system. And after that, we will perform the ultrasound scan following a 6-step approach as per recommendation of the International Society of Ultrasound in Obstetric and Gynecology. And after performing the ultrasound scan, then we will need to share the report with the patient. And if she has some question, and then we will allow her again to ask the question. And then after that, we will be done. So stay tuned, we will be back. Yes. Yes.
Bit of patience.
You can sit down. Good morning. So I'm Dr. Kabulu. I'm a obstetrician gynecologist here, specialist. So we will be performing an ultrasound scan on you. An ultrasound, it's a technology which uses this machine so that we can be able to see the baby inside and examine the baby. And because you are in third trimester, means almost term, we usually do an ultrasound scan first to see what is the position of the baby, because you know it's very important that we know what is the position of the baby, the presentation of the baby, to be sure that you will be allowed to deliver normal or otherwise. Okay, that's first. Second, we would like to know how big the baby is, because if it's big beyond the measurement of the way the baby will use for delivery, we won't allow you to deliver normal. Hang it.
That means it.
No.
C-section.
No, in case it's bigger.
In case
It's bigger beyond 4 kgs. We usually go for Caesar because we can encounter complication if the baby is bigger like that. So the ultrasound now will first help us to see what is the position and the presentation of the baby. Second, how big the baby is, the amount of fluid around the baby, and where is the placenta. You know the placenta?
Yeah.
The placenta, in Siswati we call it umnagab. Hang it? Yeah, so the umnagab, is it in the right place or it's actually on the wrong place, means in the way the baby is using for delivery. In that case, we decide to go otherwise. So basically that's what we will be doing. I don't know if you have some other question.
No, I don't.
Okay, should we go for the movie?
Yeah.
Okay. As you can see, before performing the ultrasound scan, we need to prepare the patient. And we prepare also the setting. The light should be dim to allow us to see the imaging which is being displayed on the screen. Secondly, for the patient should be at her ease. She should be laying down, and most of the time the patient is on our right-hand side. And we cover the patient, we cover the clothing of the patient to protect it from the gel, as we just uncover the area of interest, means the area where we will be performing the ultrasound scan. And patient should be also able to get a look on the screen. Should she willing to see what we're doing and how is the baby doing inside there. So that's it. The bed has been set at a level which will allow me to perform the ultrasound scan properly. Also, the stool is adjusted at a height which will allow me to perform the ultrasound properly. So now let's get started. So now we will start the performance of the ultrasound scan. And the first thing we do after talking to the patient about the indication of the ultrasound scan and how is the process going to be performed, we need to enter patient details. So your name. Wait a bit. Yes, as I said, before starting performing the ultrasound scan, or the fetal examination using the ultrasound, we first enter the patient details. And the patient details, it's the name of the patient, the age of the patient, the last menstrual period, we have what we call the obstetric formula. How many pregnancies, how many babies alive, how many miscarriages, ectopic pregnancies. Those are information we enter. And on top of that, we also put the vitals, the BP, the pulse. We also enter the height and the weight, and the machine will automatically calculate the BMI of the patient. And apart that, if there is any additional information we need to enter, there is a space for that. For instance, if she's diabetic, if she's hypertensive, any risk factor which is important to be entered as an additional information, those are needed information we need to enter before we start performing the ultrasound. And after doing that, then the next step is to choose the appropriate probe according to the area of interest we want to examine. But in this case, knowing that we are performing an obstetric ultrasound scan, we usually choose the K-liner probe with a 3.5 megahertz frequency. And then apart the choosing of the probe, we also choose the preset which is which is aligning with the gestational age, the BMI of the patient, and exactly what we want to do. And here, the preset has been taken for second and third trimester. Yes. So, having said that, the next step is to apply the gel. The gel, it's very important because it stops air to interfere between the probe and the tissue we are examining. It's a little bit cold, I think. So that the image is clearly displayed on the screen. So as we're starting to perform the ultrasound scan and we choose the appropriate probe, the other thing we need to check on the probe is the orientation of the probe. So we orient ourselves from the patient, but we also orient ourselves from the probe. And all the probes, they have a marker, and that marker is used as a reference. And that marker, as we are performing the ultrasound, the marker is here. This marker should face us as we go for transverse view or transverse section. It should be face us. And to start, to be sure that we are holding properly our probe and we are orienting in the right direction our probe, we use the marker, but we can also use a pressure applied on the abdomen. Why? Because the right side of the patient should be displayed on the left side of the screen. And to check that, that's why I'm applying this pressure, and it can be seen on the screen as you can see. The other way to be sure that we are the orientation, we have a proper orientation of our probe or transducer, is to slide our probe from left to right using the narrow axis of our probe. When you move to the left-hand side of the patient, the image on the screen should be going opposite side, means towards the right side, and so forth. So, starting the ultrasound scan, we always start with transverse plan of or section of the probe. And here, before I proceed, I would like to say the probe moves. We use 4 moves of the probe. The first one is to slide using the narrow axis of our probe. slide using the broad axis of the probe. That is sliding. We have rotation as the other movement of the probe. Apart from rotation, we have the dipping. That is dipping. Angling. That is angling. And we can have combination of this as well. So we have the sliding, rotation, dipping, then angling. So now, we always start transverse view, and once just above the symphysis pubis, and then we try to do small angling of the probe to try to see which is the presenting part of the patient. And as we can see, this patient, this fetus is in is cephalic, because we can see the head. And as on the introductive part, I was talking about using some of the control. Is that we use the right hand to hold the probe, and we use our left hand to maneuver with the control on the scanning unit. So, as I was talking about increasing or decreasing the gain, is just turning as one would have turn up the volume on the stereo. The higher the overall gain, the brighter the image. The lower the gain, the darker the image, as we can see, using this scale next to the. So here, first step, using the 6-step approach recommended by International Society of Ultrasound in Obstetric and Gynecology. The first step will be to determine the presenting part of our fetus, which we have completed, and here we have a cephalic presentation, means the head is down. The second step is actually to look for the fetal heart beat. And for that, we need to maintain our transverse plan and slide on the slide upward towards the umbilicus using the broad axis of the probe, being in the mid section. As we can see, we have the heartbeat, and I will allow the patient to have a look on the heartbeat of the baby. So what you are seeing flashing like this, that is the heart of your baby, and we can listen to it. Now that I would like to measure how fast this heart is beating, I will use the control we call the freeze. As I said prior, freeze control help us to freeze our imaging on the screen, and then perform the measurement. Then, as I press measure, this is another control. By pressing this, we can see all the measurements a range of measurement we would like to perform. And here we would like to know how fast the heart is beating, means the fetal heart rate. Our screen is a touch screen, so I can just touch on the screen and then go for two peaks. And when we take 2 peaks, in some other ultrasound scan machine, we take 3 peaks. And here it's 2 peaks, which makes it 130 beat per minute. 130 beat per minute. Okay. So now, second step being completed, which was a determination of the fetal heart rate, which has been done. Then we move to the third step. The third step being to identify how many fetuses we have inside it, means how many babies. For that, we maintain, you can focus on the probe, we maintain the transverse sweep on the of the probe, and then we will need to move to slide using the broad axis of our probe from the symphysis pubis on the right hand side towards the fundus of the uterus, using 3 monthly tracks, the right one, the middle one, and the left one. So I will start from the right one, going from the pubis towards the fundus of the uterus. And there we can still see the baby. Then back again in the middle. Can now focus on the screen, going upwards the fundus, still seeing the very same fetus. And then on the left track, same, we can still see only 1 fetus. We can complete this step, you can focus on the abdomen, by rotating our probe 90 degrees clockwise. This movement will help us to move from transverse view to longitudinal view. And then we do the sliding from right to left, sweeping from right to left, first under the umbilicus, going to the left side, and then secondly, slide from right to left using the broad axis of our probe. Then we show that we have only 1 baby inside. That was the step 3. After the determination of number of fetus inside the womb, we will move to the 4th step. The 4th step being the location of the placenta. For the location of the placenta, we need to rotate our probe 90 degrees, moving for transverse view to longitudinal view. And we will slide using 3 tracks, mentally, 3 tracks. 1 from the fundus towards the symphysis pubis on the left, the right hand side, 2nd in the middle, and 3rd on the left hand side of the patient. So we maintain our probe perpendicular to the floor in longitudinal view. Then we slide from the fundus towards the symphysis pubis. That is on the right track. Middle track, same, from the fundus towards the symphysis pubis. And third, from the fundus on the left hand side track downwards. Now, I will still demonstrate. We were demonstrating the movement of the probe, focusing on the abdomen. Now I would like us to focus on the screen as we are doing the same. So I'm on the left track, going from the fundus towards the symphysis pubis. I can tell I can't see the placenta for now. On the middle track, and on the left track. Then on the left track, that's where we can see properly the placenta. We can tell the placenta is anterior because it's closer to the probe, posterior being away from the probe. So our placenta, as we can see here, is anterior, but on the left lateral. As we're going down, so we look at the position of the placenta as anterior, but we also see the leading edge of the placenta in relation to the internal os, if it's away or closer to it. That's how we rule out placenta previa. So here we would say the placenta is anterior on the left lateral on the upper segment of the uterus, which is normal in this case. And then we will move to the fifth step. The fifth step, which is estimation of the amount of the amniotic fluid. For that, we need mentally, indeed, to divide the abdomen of the woman in 4 quadrants by drawing 2 lines passing via the umbilicus, one which is longitudinal or vertical, and the other one which is horizontal, dividing the abdomen in 4 quadrants. The first is the right lower quadrant, the second the right upper quadrant, left upper quadrant, left lower quadrant. So how do we estimate the amniotic fluid amount? First, here I think it's important to remind that fluid doesn't send back an echo from the probe. That's why it appears black on the screen. That's why it appears black on the screen. Why? Because any fluid, whether it's urine, whether it's amniotic fluid or blood, it doesn't send back an echo towards the probe. That's why it appears black. And by the way, amniotic fluid offers to a sonographer an acoustic window which allows other tissues or organs to appear clearly on the screen. So, to estimate the amount of amniotic fluid, we need to be in transverse view with the probe being perpendicular to the floor and then we slide using the broad axis of the probe, looking for the deepest vertical pull to be measured. So, sorry. Small contraction, huh? No, it's okay. Our patient is in latent phase of labor, so time to time she has a bit of contraction. So once we get a deepest pull like this, what we do is to go for, we freeze first to freeze the picture on the screen, then we go for measurement. And for measurement, we press measurement and it displays what we would like to do. And in this case, what we want to use as measurement is amniotic fluid index. By the way, as we're talking about measurement of the amniotic fluid, it's done in two ways. The first way being amniotic fluid index, where we divide the abdomen in 4 quadrants, and then the index or amniotic fluid is actually the sum of all the measurement in all the 4 quadrants. But we can also go for the deepest pull volume, DVP. That one is, we look at which one is the deepest among the 4. It's another way of doing that. But here we'll demonstrate the 4 quadrant. So I press on Q1, Q4 quadrant. That's the first one. Then I go in the right upper quadrant. And as we can see, that is the deepest pull. Again, I freeze, then press the measurement. We go for the second quadrant. Here, of note, we need to measure only the fluid, strictly the fluid, nothing else. That is the second quadrant, and then we move to the third, which is the upper left quadrant. As you can see, I still maintain the transverse view. The probe is perpendicular to the floor. And then I survey the whole quadrant with my probe to get which is the deepest. And I think that one is the deepest. Again, freeze, then measurement. I select the Q3, which is third quadrant. Again, we measure strictly the fluid only. After that, I unfreeze the picture. Then I slide, maintaining my transverse view, probe being perpendicular to the floor, and then I survey the fourth quadrant, which is the left lower quadrant. I survey the whole quadrant. And this will be our deepest pull. Again, freeze, measurement, select Q4. Strictly fluid. And our machine is able to calculate the amniotic fluid index by making the sum of the four quadrant. So our amniotic fluid index is 214.3 millimeters, which is on the upper limit of the normal, so which is normal in this case. And if it was for the deepest pool, we would have taken the third one, which is 73, which is the deepest. If it was to take only one deepest pool, one deepest vertical pool, it's Q3, which is 79.5. That is another way of assessing the amniotic fluid. Okay, now we'll go for the last step, which is the sixth step in the six-step approach performance of ultrasound scan. So we always start from the middle. We have our probe, which is in transverse, give us a transverse plane with the mark of the probe facing the operator, which is me in this case. And then we look at the screen, and then we get the shape and the intracranial landmarks of what we want to measure. In this case is BPD, and BPD goes for the fourth plan of the International Society of Ultrasound in Obstetric and Gynecology, which is a transventricular or transthalamic view. Then I freeze. Again, I press measurement, and the first measurement to be done when we do fetal biometry is the BPD and the BPD, which is biparietal diameter, and the HC, which is the head circumference. So I will start with the BPD, just hit on that, and then depend on the protocol of the house, it can be outer or outer inner. So I go for outer. I go on the wider diameter of the head on the parietal bones, and then it should be perpendicular to the midline, which is the falx cerebri, and then we press to validate, and then I go for HC. HC again, I will put the caliper on the outer border of the cranial bone, or the skull bone. Bones. Open it up, validate, and then bring it closer and validate. And that is done for the BPD and HD. Then I unfreeze. I go for the second measurement, which is the abdominal circumference. I maintain the transverse view and slide upwards towards the umbilicus using the broad axis of the probe. Again, we get the heart, and then we move slightly to get the abdomen. And then once there, we still need to do some small rotation, some small angling and sliding to get a proper, our fetus here is facing the back of the mother. I will apply a little bit of gel again. So always not hesitate to apply a bit of pressure using our left hand to get a proper. So here I'm sliding on the narrow axis of the probe. To get the landmarks or references. In this case, we have the stomach and the inner part of the umbilical vein. Once we have those two like that, then we can go for measurement, AC. Then I will put the caliper of our ellipse on the outer board of the abdominal wall, and here I need you to note that the AC is one of the important measurements which allows us to estimate the fetal weight. And then after that, validate, and then we go for the last measurement, which is the femur. So we maintain our transverse view with the probe, but continue to slide on the broad axis of the probe, going towards the pelvis of the fetus. Once we are on the pelvis of the fetus, we can then do a rotation, 90-degree rotation. And as I said, we need to combine some movement sometimes. As we can see on the screen now, we have our femur, but the femur is not horizontal. Because it's not horizontal, I need to dip as another movement to make it horizontal. Now that it's horizontal, we are losing part of it, which is out of the braid. Then I will need to slide on the narrow axis of the probe to get it in the middle of the screen. Now that I've demonstrated combination of movement, we've been focused on the screen. I would like us to focus now on the movement of the probe. Again, we go from the AC, we slide using the broad axis of the probe up until we reach the pelvis. And as we reach the pelvis, I do some small rotation and I can identify the femur. As the femur is identified, then it's not horizontal. I dip to make it horizontal. Then I combine the dipping with the sliding on the narrow axis of our probe, and we can get a look on the screen now. Our femur is really horizontal. Then we freeze, and we need to measure only the diaphysis of the femur to avoid any spare artifact. So again, measurement, femur, and then we measure only the full length of diaphysis, avoiding the spare artifact. So moving the probe this way allows us or prevents us from accidentally measuring the humerus as the femur. So with this being done, we are done with the fetal biometry, and then with all these measurements we have done, we can now check the report and see. So to review the report, we press the control report, which is here, And then, as you can see, the report of all the measurement we did is displayed on the screen, and we can actually scroll down to get everything. And our baby estimation fetal weight is 3.3 kg plus minus 500. As we can see on this screen, we have BPD. We have two weight, 3.3 and 3.5, and 3.5. So we take the weight which take into consideration 3 measurements: BPD, AC, FL. That's the one which is more accurate than this one, because this one is taking into consideration only 2 measurements, which is AC and FL. So that one is more accurate than this other one. So those are the 6 steps in performing the ultrasound scan. Okay. After finishing the performance of an ultrasound scan, we have what we call the aftercare. The aftercare consists of what? First, we clean the probe. And to clean the probe, we again use our paper. We clean, why? Because the gel, when it's left here, it can damage the probe. Remember that we talked about piezoelectric crystals, which are really fragile, and they are in there. So after performing the ultrasound scan, we clean the probe and we put it on the probe holder on the machine, protecting also the cable, because the cable are also vulnerable to damage. So, and the probe is one of the expensive component of the probe, so it needs to be handled with care. And the cable needs to be looked after. After that, we wipe off all the gel on the abdomen of the patient, and we allowed her to sit. And then we share our findings with the patient. We should here be reminded that all this is within the process of antenatal care. And antenatal care recordings are on the PIN card of our patient. And this is why I was saying performing this ultrasound in our patient is it's aligning with our Eswatini ANC guideline. So the findings, we share them with our patient, is that your baby, as we said prior, I talked to you before we perform the ultrasound scan, we say that first we will need to determine what is the position of the baby. And your baby is in cephalic presentation. Cephalic presentation means the head is down, which is the proper position and presentation to allow the baby to be delivered in the normal way. That was first. Second, it's to determine if the baby is alive or not. To be sure that the baby is alive or not, we check the fetal heart motion. And then we also measure to see how fast the heart is beating. And here we can say your baby is alive and the heartbeat is 130 beats per minute. Normal range going from 110 to 160. Okay? The other thing I said was to check how many babies do you have in there, in the womb. And we checked that one, we have only 1 baby. Okay? Yeah. And the other thing was to determine the location of the umnagab being the placenta. And yours is in the normal location, which is anterior, most on your left hand side on the upper segment. When we say upper segment, what we mean is that the placenta is not blocking the way to the fetus, okay, to the baby. And What is the weight of the baby? I told you that it's 3.3. Because there is always a margin error, then we say 3.3 plus minus 500 grams. 3.3 kilograms plus minus 500 grams. And the amniotic fluid, the fluid around the baby, is in a normal amount we have measured. So, in short, konke kuhamba kahle, as we say in Siswati, everything is fine, and we wish you all the best for the delivery. Now, I would give you the floor. If you have any question, any concern, you can ask, and then I'm available for answering to all the questions. Okay, everything is fine.
Yeah.
So I will hand over to you this report and then allow you to leave and go inside so that the midwife can attend to you and assist with delivery. Okay. Yeah, you will also give them that. Those are information they usually need to assist you with delivery. Okay, bye-bye. So, I would like to wrap up what we did today. We were trying to demonstrate how we perform the obstetric ultrasound scan. And the first step being the preparation of the performance of the ultrasound scan. During this step, that's where we talk about we talk with the patient about what are we going to do, why are we performing the ultrasound scan, and we allow the patient to ask questions. What we did, and after that, we install the patient at her ease for her to be comfortable. We cover up her clothing, and we uncover the area of interest where we will be performing the ultrasound scan from. And after that, we perform the ultrasound scan using the six step approach as recommended by the International Society of Ultrasound in Obstetric and Gynecology. What we did, and after that we go for aftercare. Aftercare consisting in cleaning the probe, storing the probe using the probe holder on the ultrasound, and then after that we clean up the gel, or we wipe off the gel from the woman's abdomen, and then we allow the patient to sit down and share the findings with the patient, and allow her again, if there is any question, to ask question, and we answer question, and after that we allow the patient to leave. That is in summary what we did. But as recommendation or take-home message is that for those who are willing to learn ultrasound scan, the first thing I would like to say is, if you are willing to learn, no one will stop you. And for that, you need to set up your mind and go for training. And after training, I would like to give an advice that we shouldn't be shy of practicing, because practice makes perfect, as we usually say. And the more you perform ultrasound, the better you get in performing the ultrasound. And as you perform the ultrasound, it's always better to be systematic following the 6-step approach as recommended by the ASIOG. So in short, that's it. And I'm looking forward to meeting you when we will be organizing the theory and practical of performance of ultrasound scan. Thank you.